Morning. My topic is on factors affecting adherence to anti-glaucoma medications in a tertiary center in North Kerala. Glaucoma is a chronic progressive optic neuropathy leading to irreversible blindness worldwide. Lifelong topical medication is the cornerstone of management. The major challenge in glaucoma treatment is adherence to medical therapy. Non-adherence itself is a risk factor for progression, hence it is important to assess the factors affecting adherence. Very few studies from Kerala addresses adherence patterns. There is limited exploration of caregiver role and socio-economic factors, limited exploration on accessibility to healthcare and medication availability. Interventional studies are lacking. Aim and objective to determine factors affecting adherence to topical anti-glaucoma medications in a tertiary center in North Kerala, to evaluate the relationship of adherence behavior with patients' demographic data and socio-economic status, to evaluate measures to improve adherence to anti-glaucoma medications. Materials and methods: study site, Glaucoma Department, Comtrust Eye Hospital. Study population: glaucoma patients on topical AGM for at least 3 months or more. Study design: cross-sectional questionnaire-based study. Patients on AGM for at least 3 months and aged over 35 years who gave informed consent were included in the study, and patients scheduled for glaucoma filtering surgery, patients with cognitive impairment or psychiatric illness were excluded. Methodology: a semi-structured questionnaire used to assess patient-reported problems and glaucoma medication adherence was distributed to the patient. Brief medication questionnaire is a validated tool for assessing glaucoma medication adherence. This was translated to local language and administered in a structured and standardized way. The questionnaire included demographics, socioeconomic profile, knowledge, attitude and practice, adherence behavior, barriers and methods to improve adherence. Adherence was defined as not missing more than 1 day drops in past 15 days on subjective assessment. Coming to the results, total sample size was 380, which included 180 males and 200 females. Demographic details: 86.8% of the participants were between 45 to 75 years. 58.4% came from more than 25 kilometers from the hospital. 65.5% were unemployed. 81.3% had education more than 10th standard. 96.6% had caregiver with them. 63.3% was on single AGM, 27.6% on 2 AGM, and 9.2% was on more than 3 AGM. This is a graph showing distribution of subjects based on AGM use during the last 1 week. 79.5% were adherent. The barriers to adherence, non-adherence identified were cost 33.2%, forgetfulness 18.4%, difficulty in obtaining medication 16.1%. Suggestions on how to improve adherence were cost reduction 40.8%, tele reminders 25%, and 18.9% opted to make medicine available at peripheral pharmacies. Regarding caregiver and adherence, with caregiver adherence was 79.8% and without caregiver adherence was 53.58%. So the adherence was significantly influenced by caregiver support. AGM adherence and distance from hospital. Adherence was significantly influenced by distance from the hospital, underscoring the importance of availability of medications at peripheral pharmacies. This is a trend analysis on AGM adherence versus distance from hospital. The blue indicates adherent population and red indicates non-adherent population. The large negative Z value indicates the strong decreasing trend in proportion. So as the distance from hospital increases, the percentage of adherent people decreases and non-adherence increases. So this suggests that greater travel distance acts as a barrier for consistent follow-up and medication adherence. We also studied regarding association of AGM adherence with other parameters like age group, sex, education and number of AGM, but none was statistically significant. So our study reaffirms that even in a high literacy state like Kerala, adherence is determined by multiple social determinants. So our study, with a comparatively larger sample size of 380, adherence was 79.5%. Our observed adherence was comparatively higher when compared to other study, probably due to strong caregiver support. The major barriers identified were cost, forgetfulness, and difficulty in obtaining medications. This was almost similar to other studies conducted by Singh K et al. And Sleet B et al. In our study, adherence was significantly influenced by distance from hospital and presence of caregiver. Strategies for improving adherence included cost reduction, daily reminders, and improved local availability of medicines. A study conducted by Rajurkar K. et al. In North India, he emphasized reminder systems like SMS and app patient counseling for as a method of improving adherence. At a global level, results align with studies conducted by Kebede B. et al. In Ethiopia. However, their adherence were 45.8%, possibly due to old age, low education, longer duration of treatment. So, our study concluded that adherence to anti-glaucoma medication was 79.5%. Cost, forgetfulness, and difficulty obtaining drugs were main barriers to adherence. Caregiver support and proximity to hospital were significantly associated with better compliance. Targeted strategies like cost reduction, tele reminders, improved access can improve adherence. So this study adds to a regional insight. This provides one of the large-scale adherence study in North Kerala, identifies modifiable barriers to adherence, demonstrates a significant correlation between distance from hospital and caregiver presence with adherence, supports integration of tele-reminder systems, cost reduction, local pharmacy drug availability into glaucoma care programs. So limitations are self-reported adherence was used. So the responses may be affected by recall bias, which may not reflect long-term compliance trend. Study did not assess visual field progression or IOP outcomes to correlate adherence with disease control. Medication cost variability, drug availability difference between urban and rural participants were not separately analyzed. Structured questionnaire assessed only short-term adherence. So the recommendations put forward are increase access to affordable AGM at peripheral pharmacies to reduce travel burden, introduce mobile-based reminders, encourage family support in daily administration. These are my references. Thank you.
You spoke about the socioeconomic status, right? So did you assess the socioeconomic status and how did you do it?
By Kupuswamy scale.
Kupuswamy, I will show it, I think, right? Okay. And then did you validate the questionnaire that you had used?
Actually, brief medication questionnaire is a validated questionnaire, but we have locally validated it in Kerala.
So you have a pilot study for
yes,
that?
we have done pilot
How many
study.
cases were there in the pilot study?
40 patients we have taken.
So they are included in this or they were excluded from this?
No, we have included that also in this.
Into this, okay. And then adherence, you said no adherence. So what is the difference between adherence and compliance?
Adherence is an active process, that is act of doing it willingly, whereas passive is what compliance is a passive procedure. They are supposed to do what doctor has been advised.
So you said even if missing one day is non-adherent, right?
Yes.
One day of the dosage also is non-adherent. Okay. And then multiple AGMs, you said that it's causing non-adherence, right?
Yes.
So did you try with fixed combination? Did you categorize them as fixed combination monotherapy or whatever it is? Or you put just anti-glaucoma drops and you looked at the adherence, that's all?
Just anti-glaucoma, we have, even with multiple drops.
Like concomitant therapy. Concomitant therapy is 3 medicines and then fixed combination is having all the medicines in one bottle, right?
Yes.
So did you check that fixed medicine has got more adherence or concomitant medicines has got more adherence?
No, ma'am.
You didn't check it. Okay. So it will be better to check that. That will give you more idea whether the patient is compliant to fixed combinations or concomitant medications, because that will reduce the cost also.
3 months is a very short time to assess adherence, no? The patient, if you had a patient who was following up for 1 year, 2 year, that makes more sense rather than looking at a person who is just into the medication for 3 months, sorry. 3 months is extremely short. Sometimes even you may reconsider
for them to even understand about the disease, it takes months.
And you have not asked questions related to their fear of blindness and things like that. That aspect has not been covered, I feel.
And you said you asked about KAP, right?
Yes.
So KAP was done twice or just one time?
One time only.
So one time is also a very short duration. Like, you have to give the KAP. They seem to appear knowledgeable after the KAP, but after the second visit, there is a limitation, like, it decreases again. So, and as he said, 3 months is a very short duration.
Thank you.